Welcome to Shreveport-Bossier Local Lens, the podcast dedicated to sharing the stories of the people making a difference in the Shreveport-Bossier community. Hosted by Jeremy Sutton, each episode dives deep into inspiring conversations with local leaders, creators, and change makers who bring unique perspectives and positive impact to our area. Hey everybody, I'm Jeremy Sutton. I'm here for the Shreveport-Bossier Local Lens podcast. I'm here with Dr. Feibel at Highland Orthopaedics. We're going to be talking about the amazing things he does. Dr. Feibel, thanks for being on the podcast.
Absolutely, glad to be here.
Yeah, awesome. So let's just get right into it. Why did you decide to specialize in orthopedics, and what really drew you to this field over other specialties?
Yeah, I mean, I'll be lying if I told you I didn't go to medical school to probably do orthopedics. I kind of tiered a little bit here and there. For me, with orthopedic surgery, it was multiple things. I love the relationship with patients, whether it's an athlete or an older person, whomever, all ages, who we were able to, identify a problem. Once we identify that problem, try things non-surgical. If we can't, we can have a procedure that can get them back doing what they want to do. For me, with joint replacement, I enjoy the instant gratification on my end,
right,
let alone the treatment of the patient, to basically just get them back doing the things they love to do, whatever it is, pickleball, hiking, jogging, anything. It doesn't matter. It's just getting them back doing what they're not able to do.
Yeah. You said the magic word, pickleball. That's what I want to do.
I joke with people, it keeps us in business. Pickleball does. Yeah. I love it because of that, for that reason, but it's actually fun to play too.
Yeah, it's fun. I looked at the pickleball PT. I was going to buy that website, but it was going to cost me more than what I think my house might be worth. but anyway, yeah. So I love that aspect, and I think I've talked to Dr. Byram before and other orthopedic surgeons, and I think the thing that y'all like to drive home too is we're not just about cutting you the first time we meet you. We're trying to get you better without it.
Next to on-call stuff and trauma, that's never the first option. Obviously, as we get busier and as people come see us and our name gets out there, some people kind of have tried that and they're coming to us for that next step.
Right.
But the vast majority are, we're focusing on physical therapy, anti-inflammatories, weight loss if that's an issue, injections, obviously, those kind of things. And we're trying everything we can, because if I can give someone 3 to 6 months of relief, that's pretty much a win in my book.
Yeah, 100%. And I have people ask me sometimes, when should I have surgery? I think when you can do nothing else but have surgery. If you've exhausted all your options, then let's put you out of your misery and let's fix this.
I tell people, that's why, someone that's had a bad knee or a hurting knee for 2 weeks, we're never going to offer a joint replacement at that time. There's something with the human body of dealing with a problem long enough to appreciate and understand the benefit you're going to get.
Yeah.
So
I love that.
Sure.
Well, what qualities or mindset would your ideal client have that contributes to a successful outcome, do you think?
People that are driven. Mm-hmm. I think people that have a goal they want to get back to doing drives their rehab and drives their recovery. Whether they're still working age or retired age, it doesn't matter. That's one. Two, I love the stubborn patient. I love the ones that are going to be very stubborn and want to get better and do their part, because I find that they do very well. Obviously, the healthier the better, but anyways, or someone that's caring about their health care to the point that they want to get better. I think if we can do shared decision making, shared plans of action to get them better, I feel like the whole system, the whole team does better.
Mm-hmm. So. Yeah, stubborn people used to scare me. Hey, I don't think this is going to, stubborn, this isn't going to work.
Sure.
I had to come here because the doctor told me.
Yeah.
But then I kind of got to where I took those as a challenge, because if you can get those better, those become lifelong patients. They become friends. It's just
so true. If we're going to call it stubbornness, fuels their recovery, because especially if you can almost use it to them, against them, saying, oh, you can't do this, and all of a sudden they're like, no, I can. Watch this.
Love it.
That really helps us.
Yeah, so. I love that. That. We're not manipulating, but we're just going.
We're utilizing the factors that they have.
That's exactly right. So what should people expect from you as their doctor from, let's say, the first time they meet you through post-op?
Sure. I always see my patients their first visit. I tend to always try to explain the pathology they have. I think because I believe that someone understands, one, what the problem is, and that's by showing them x-rays, MRIs, whatever, showing them their clinical findings. If they understand the problem, number one, I think that's the key. Then, if it's a surgical issue, explaining what I'm doing to them. I've been shocked for people who have had surgery done elsewhere, even by me at times, if I've not done a good job of explaining it, and I find out that they did not understand what I was doing to them. I think if they understand from beginning to end what I'm doing, then basically they do better. Mm-hmm. And the more they understand every facet, therapy, wound care, everything, I feel like that makes them do better. And then the last thing is they're never getting rid of me. I view them as a lifelong physician to them. I have to beg some of my total joints to come back at a year, but I like seeing them at a year because that's when I tell them it takes a full year to get over that joint replacement to get as good as you're going to get. And I like to see that, to see, oh, I see what you're saying. Factor X is easier to do. Whatever it is easier to do than what it was before.
Mm-hmm. Yeah, I love that. I do that with people too. If I see somebody once, I consider myself your PT forever.
Yes.
And I'm like, just call me. Until you die or I die, you can call me. 100%. You can ask me questions. I'm not billing you for a phone call. No. Like, let's just interact because even if, I lived in Ruston and then I've pretty much done my whole career over here and some in Minden. But like, I know people still in Minden and they'll be like, hey, who do I go to for PT?
Yeah.
I'm like, well, don't drive all the way over here, but you can go see, Luke Guin in Minden, or you can come see Mark Hart in Bossier, or whoever you want to see.
Sure.
Because I want to serve them. It's not always about getting something from people, right?
No, it's just, I enjoy, I tell them, when I see it, I call it the goodbye visit. When I see them the last time, I say, hey, if anything starts to bother you, any other joint, the joint that I worked on, doesn't matter. I'm here, and I'm here to take care of you.
Yeah, absolutely. I absolutely love that. So explain a little bit about the difference between a normal total knee replacement and then what you do is the Mako robotic arm. What's that different? Why is that better?
Sure. Manual or the old school type method was used for years, and it was effective. What I learned in fellowship and kind of when I got into practice is I believe I'm very good at what I do, but I'm not 0.1 millimeter difference to be able to tell. And what I've learned with the Mako robot is I can make very, very subtle, small adjustments on these patients, whether it's a hip or a knee, that can give them a very personalized approach and personalized fix to their problem with a new joint. Because what the studies say, and what I actually personally agree, if I can manipulate the bony cuts with the robot essentially is helping me make the cuts without using old school jigs.
Right.
I can make adjustments, and that's less soft tissue stripping, which means less swelling, less pain, and give them more of a native anatomy of what they're used to. I'm not overly correcting them like the old school techniques were. And that helps with pain relief, increased function, and getting back to what they want to do faster. Mm-hmm. So
yeah, with the robotic, from a PT standpoint, does that give them better range of motion afterwards with a knee replacement, or is it still about the same?
It's probably about the same, but the problem is it's predictable. So in every one of my reports, I put, because I can measure their extension and flexion, I know what they did when they were asleep. So I know that is obviously the best they're going to get. Right. But I know that this patient flexed to 145 degrees. It can be done.
Wow.
And so I know that, okay, if they come back in 2 weeks, they're behind, or, if they're 85 or 90 degrees, my goal is 0 to 90 at 2 weeks. Anything more is great. I know that they've got more in them, and I know that we can make a difference. And I kind of know, too, going forward, if anything changes, where we were. And so having measurable things, visual metrics to look at during surgery, I think that's pretty cool. And that's the future. And I think as we track it more and more, we're going to see that I do think it is superior overall.
Yeah. Mm-hmm. So you're one of those while you were asleep doctors that have given me so many headaches over the years. And my patient's like, I swear it was at 145. I'm like, let me knock you out.
I don't tell them that. I just document it for my own, and then I tell them, and they're like, especially if they had a big deformity or their motion was poor before, and I'm like, oh, we were able to start with this because I have that metric too. Yeah. We got you to this. Yeah. This shows that, hey, you can do it. Mm-hmm. Therapy is very important, especially for my knees, just because I find if they were stiff before, as you know as well as I do, they're more likely to be stiff after. That's why you guys as therapists are so important to keep what we gain. I tell them all, I make my knee patients 3 promises. I can make your pain better, I can give you a knee you trust, and I can get your motion better. Yeah. The motion's on you to keep it. That's what I tell them. And I think, again, that goes back to the buy-in and the shared decision making and everything. I feel like that increases their buy-in and makes the outcome better. Yeah.
One of the things I always ask after a total knee is how long was your knee stiff before?
Sure.
Because if it was a month or 2 months, then hey, we're gonna blow and go. But if it's been 5 years, then hey, I'm Jeremy. We're gonna spend a lot of time together, and you're gonna hate me.
Exactly.
I love that though. I mean, you got to set expectations right.
I'm all about that. I think I think, you have someone that has a real problem, a very large deformity, a very large contracture, or whatever it is, whether it's hip or knee or any kind of revision surgery, making them understand what our goals are and what to expect, because, I gotta tell them, if you weren't running 5Ks before, I can't make you run
exactly
5Ks
right.
after. And so, but at the same time, I think it's important to set that, because then there's no surprises, or there's less surprises.
Right. Yeah. So my first PT job was at Health South in Ruston, and I had a lady on a scooter, and she said, I need to be able to walk in 6 weeks for my daughter's wedding. Huh. And I said, when was the last time you walked? It's been 3 years. I was like, oh my gosh. Now I'm better equipped to answer that question.
Sure.
But then I was just like, oh, ma'am, I don't know what to tell you.
Right.
So also, well, you talked about your fellowship a little bit at Southern Illinois University School of Medicine. How did that shape your skills and then influence to where you could come back here and serve the community?
Yeah, that's a great question. So I was blessed to have phenomenal training at LSU. At Shreveport. We saw a smattering of different type of patients, did quite a bit of orthoplasty. And so I felt like I was a very good general orthopedist when I graduated. Fellowship did a great job of taking that and utilizing that to hone those skills to be better. And to me, it's in doing a very good primary joint, which takes repetition, and doing a very good revision joint. And the way I was taught, if you can do a good revision joint, you can do a very, very good primary joint. And so, for those that don't know, a revision joint, basically a knee that's been in there or a hip that's been in there, we're going to redo part of it or some of it or all of it. And I used that. It was a very high volume place, significantly autonomous. Day one, I was doing surgery, able to get my hands wet. And a lot of that I attribute to LSU because they trusted me, because they quickly saw that I had the abilities that some places that doesn't have that ability, because it's not taught, and you're not doing as much as early as we did at LSU.
Yeah.
But again, it shaped everything. I modeled my practice. I had some phenomenal mentors there, young guys, old guys. One guy's been there for 40 years. He's still practicing. He's the go-to guy I have, and I've got my young guy too that I call too. But it made you very comfortable.
Good.
And when I first started, the surgical part was not the scary part. The scary part was pitching up a sign as an elective joint surgeon and hoping people show up and get it replaced. And that was the part that was the most scary, but it wasn't the surgical part. It was pretty neat.
That's funny. Tell me, this isn't on the list, but why was that the scariest part?
Well, having patients to take care of was never a problem. It was never an issue. Medical school, residency, fellowship, they were always there. And I was just a guy helping doing the surgery, whatever. But even though I'm from here, pitching up a tent, pitching up a sign saying, hey, come see me there's phenomenal joint surgeons, phenomenal orthopedic surgeons in this town. Why me? And that was the part that made me the most nervous. And by the grace of the good Lord alone, it worked out. And we're doing a lot.
That's
so
good.
It's good.
That's good. We really do have amazing physicians here in Shreveport-Bossier. It's crazy. Well, we got 2 more quick questions. What are some common misconceptions about joint replacement surgery that people have that you hear?
It's funny. Most people, it's the lack of understanding of the ability. They think it is a major surgery. They think of it as a broken knee, a broken ankle, where they basically can't do anything. And especially in 2025, we're getting them up an hour or two later, showing them they can do things. And especially for my hips, you can do whatever you feel like doing. That's one. And then on the other side of the coin, the conception of what we're doing in replacement surgery. I think people have a misconception that we're just taking out the very end of their femur, the top of their tibia, taking it all out and putting it on with metal, when it's actually more of a resurfacing.
Right.
And I think, again, that goes back to the importance of explaining what you're doing, how you're doing it. I'm a big model guy. I will show them what I'm doing. This is what's going to be in your knee. This will be in your hip. And they get it. And then just the level of function. 60 is the new 40. And people are doing a lot more than they did in 60 than they used to. And so telling them, no, you can do that. You can go hike the Tetons. You can go do this, do whatever you feel like doing, as long as it's safe and all those kind of things. But I think that goes back to managing expectations. And so that's the big thing.
Yeah, you just taught me something, because that's kind of how I've explained a total knee. Like, they're going to shave off this tip, but the resurfacing sounds a whole lot better, right?
Well,
because that's what you're doing.
Yeah, you look at an AP X-ray, and all they see is metal.
Right.
And of course, I do it every day. But then you show them a lateral shot, and they're like, "Oh, I get it." It all clicks to them.
Yeah.
So I think taking that, it doesn't take long. It
No,
takes 3 to
sure.
5 minutes to show them, and I think it makes a huge difference in their outcome.
Yeah. What's exciting you the most right now about surgical interventions?
I mean, I love all of it. I think the future is really cool. I actually am using the robotic stuff for revisions too, just because I can plan so much beforehand and then execute that plan. That's cool. I'm very big on same day discharge if the person's medically fit to do so, because that is the only plus of COVID is it taught us how to do that.
Yeah, you can get out.
And of course, in orthopedics, especially, we study everything, and we found the outcomes are better when they go home if they're medically stable to do so. And I think that's cool. I've pushed that along when I got here, and I think it's made everybody in our group do that, and people are doing better.
I love that. So I worked with Dr. Ballard over in Ruston when I was going to tech, and he did all the same day, like total knee, you get up and walk that day.
Yeah.
And people absolutely hated us.
Yes.
But they did well. Like if you can get up and walk, let's get up and do it.
Correct.
So I love that.
And the big thing about that is having the multidisciplinary teams. It takes, I tell people, we need everyone on board, from the nurse to the joint navigator to the anybody, because if someone casts doubt in someone's head,
it's over.
Especially if they've had a joint before where they spent a day or two in the hospital, that's all they need, and then all of a sudden it's taboo. But if everyone's on board and they realize that, hey, this is why we're doing this, and I think it's a job as a physician to teach them, that you will do better, and you're going to like it, because you don't want to sleep in your own bed, because a hospital is not a hotel.
You can't rest at the hospital.
You're not sleeping in the hospital.
Yeah, absolutely. Sure. One of my dad had cancer years ago, and he was sitting in somebody's office, and they were telling him about this. He was going to see Dr. Moore, who passed away a few years ago, who was phenomenal with my dad. And this lady was sitting in the office. She was telling him like every horrible thing she'd ever heard about him. And I was like, Dad, nobody tells the good stories. Like when you go sit in a doctor's office, they want to tell the horror stories because it gets attention. They go, oh, what you doing? So I love that you're talking about, hey, we can't put doubt as providers, as practitioners in the head. The whole team has to be together.
Correct. That's true. And so I think that's the future, and that's what I'm excited about. And I don't know, I think it's just fun, and just taking care of more people, and giving them good outcomes. And because I give everybody 2 rules after surgery. I said, don't fall, and tell your friends. That's
absolutely.
And so and because there's no amount of marketing, there's no amount of anything you can spend than patients saying they're doing well.
Yeah.
And that's why we're here. That's why we do. You do what you do, and I do what I do. Is making people better and giving them an outcome they like and that they're proud of.
Absolutely. I love it.
For sure.
Yeah, awesome. Well, Dr. Feibel, thank you so much for being on the podcast. I appreciate it.
Man, thank you guys.
Thanks for listening to Shreveport Bossier Local Lens. Be sure to subscribe, rate, and share the podcast to help us spread the word about the amazing people in our community.